PRP has proof, PRF has promise. But which one actually helps your hair in the real world? Today, I'll show you the science, the protocols, the experience in the chair, and exactly how I use each treatment in a complete plan, so you can decide with confidence, not hype. I'm Dr.Ko, a hair transplant surgeon in Seoul. Patients ask me every week, PRP or PRF, what's better for me? Both come from your own blood and both aim to wake up miniaturizing follicles, but they work a little differently. Therefore, we'll compare what they are, how the prep really works, candidate selection, session plans, pain and side effects, cost and standardization, and where each fits in a bigger strategy. PRP stands for Platelet-Rich Plasma. We draw a small vial of your blood and we spin it at relatively higher force with an anticoagulant. That separates a platelet-dense plasma layer from red cells and most white cells. Inside that gold are growth factor, VEGF, PDGF, IGF-1, and others that signal repair, angiogenesis, and a longer anagen phase. PRP is burst treatment. Growth factors release quickly, over hours after injection, and that burst can improve scalp microcirculation, calm low-grade inflammation, and thicken miniaturized hairs. Therefore, across many studies and many clinics, PRP shows predictable improvements in hair shaft diameter and density, especially in early to moderate androgenetic alopecia. PRF is platelet-rich fibrin. Same blood, different processing. We spin at lower force and without anticoagulant, and the sample clots naturally. That clot forms a fibrin scaffold that traps platelets, white cells, and some stem cell-like populations from the buffy coat. Because of the fibrin matrix, growth factors release slowly over several days. So PRF is like a time release signal rather than a single burst. Patients love that idea, and I do too, but enthusiasm is not evidence. Therefore, we need bigger, longer, and more standardized trials to prove durable superiority over PRP. Let's talk evidence quality. PRP has more years of data, larger cohorts, clearer protocols, and better replication across clinics. PRF has early-stage literature, often less than 50 patients, 3 to 6 month follow-ups, and highly variable processing such as tube type, spin force, spin time, and clot handling. This matters because when protocols vary, results vary, and you can't know why. Some head-to-head data show PRF slightly ahead on certain short-term measures, but small samples limit conclusions. Therefore, the prudent position today is PRP remains the benchmark, and PRF is promising yet unproven as a clear replacement. Now, let's talk about candidacy. Best responders can be patients with early to moderate androgenetic alopecia. Men and women both can benefit. Also, women with diffuse thinning can experience the thickening effect. Least ideal candidates are patients with shiny, fully bald scalp with minimal hair. PRP and PRF can optimize surrounding hair, but they won't clone follicles. Red flags. Patients who should discuss with your doctor first. Those with active scalp infection, significant platelet disorders, heavy anticoagulant use, uncontrolled autoimmune disease, or pregnancy. You may feel better hair at 6 to 10 weeks, but clearer photos and trichoscopy changes typically appear after 12 to 16 weeks. Realistic goal is to have thicker, stronger existing hair and improve stability, not a brand new hairline where follicles no longer exist. If nothing changes by month 4 to 6, you should reassess dose, frequency, technique, or the overall plan. No injection is a standalone solution. I use a 3-lane framework with all my patients. 1. Prevention lane. Use finasteride or dutasteride to reduce DHT and slow future loss. 2. Stimulation lane. Use PRP or PRF, plus topical/oral minoxidil, and optionally low-level laser to thicken what you still have. Third, augmentation lane. Use hair transplant when there is a true void that biology can't refill. These lanes multiply each other. PRP after a transplant may support overall scalp environment and patient satisfaction, but it isn't a substitute for surgical density in areas that are truly bald. Therefore, we tailor the mix. Age, pattern, family history, goals, and downtime all shape the plan. So what do I recommend? The answer is to default PRP because it's standardized, predictable, and supported by stronger evidence. PRF, I consider it for specific patients who understand the early evidence and prefer a sustained release concept, and we set expectations clearly. PRP has proof. PRF has potential. Both can help the right patient and neither replaces a smart, integrated strategy. Therefore, if you're considering treatment in Korea, bring your questions and your goals. We'll map a plan that respects your biology, your timeline, and your future.